Femur, distal, fractures. Intramedullary fixation demonstrated with the RFNAdvanced Retrograde Femoral Nailing System, RFNA, using standard locking and the locking attachment washer. Learning objectives. Upon completion of this presentation, you should be able to state the clinical indications, describe the correct patient positioning, recognize the surgical approach and entry point, perform reamed intramedullary nailing using the RFNA, and perform the key surgical steps. Clinical indications. The RFNA is indicated for the stabilization of fractures of the distal femur and the femoral shaft, including supracondylar fractures, including those with intra-articular extension, combined ipsilateral supracondylar, intercondylar, and diaphyseal fractures, ipsilateral femur-tibia fractures, femoral fractures in multiple trauma patients, periprosthetic fractures, fractures in the morbidly obese, fractures in osteoporotic bone, impending pathologic fractures, and malunions and non-unions. Patient positioning. The patient is commonly positioned supine on a radiolucent table. The knee of the injured leg should be flexed 30 to 40 degrees and supported over a bolster or radiolucent triangle. A bump placed under the right ipsilateral hip may help to prevent external rotation of the proximal fragment and malrotation. The image intensifier is positioned to allow visualization of the proximal and distal femur in the AP and lateral views. Some surgeons choose to prep and drape both lower extremities into the field for comparison. Fracture reduction. Closed reduction is performed manually by axial traction under image intensification. If reduction cannot be achieved with a closed approach, percutaneous or open reduction will be needed. Surgical approach. Depending on the type and location of the fracture, a transligamental ligamentum patellae or a parapatellar incision is made. The approach is directly midline between the patella and the tibial tubercle through the skin and subcutaneous tissue in a straight line, and then to the patellar tendon with a vertical midline split through the patellar tendon to deliver access to the proper entry point. Determine entry point. The entry point for the RFNA is at the top of the intercondylar notch, just anterior and lateral to the femoral attachment of the posterior cruciate ligament and aligned with the medullary canal. A slight posterior to anterior trajectory improves nail passage. Nail insertion. The instruments used include the handle with quick coupling, the protection sleeve, the multi-hole wire guide, the guide wire, diameter 3.2 mm, the drill bit, cannulated, diameter 12.8 mm, the universal chuck, the reaming rod with ball tip, the flexible shaft, the Synream reamer heads, the holding forceps for reaming rods, the depth gauge for nails, the elongation tube, the nail assembly instrument, the connecting screw, the insertion handle, the combination wrench, and the combined hammer. Insert guide wire. The handle, protection sleeve, and multi-hole wire guide are assembled, and the assembly is inserted through the incision to the bone. While firmly holding the protection sleeve, the guide wire is inserted through the wire guide in line with the anatomic axis of the femur. To an approximate depth of 10 to 15 centimeters, the guide wire position is verified under image intensification with AP and lateral views. The wire guide is removed. Open medullary canal. Using the protection sleeve and cannulated drill bit, drill over the 3.2 mm guide wire until the drill stop on the drill reaches the protection sleeve. The drill bit and protection sleeve are removed. The guide wire is removed. The reaming rod with ball tip is inserted using the universal chuck. To determine the nail length, the depth gauge and extension tube assembly is passed over the reaming rod to the nail entry point. The nail length is read directly from the depth gauge. Here, the nail length is determined to be 350 mm. The surgeon should account for any shortening or lengthening at the fracture site when choosing the nail length. Reaming. If necessary, the femoral canal can be enlarged up to the desired diameter with a series of medullary reamers. Sequential reaming begins with an 8.5 mm reamer head and is increased in 0.5 mm increments up to a diameter of 12 mm. A holding forceps or rod pusher can be used to retain the reaming rod as the reamers are extracted. Nail insertion. The nail assembly instrument is securely threaded into the connecting screw. The assembly is fully inserted into the insertion handle. The tip of the nail assembly instrument that protrudes through the insertion handle is aligned into the center of the nail and inserted, taking care to match the geometry of the insertion handle with the notches in the nail. The connecting screw is turned to secure it to the nail. Confirm that the connecting screw is securely tightened to the nail using the combination wrench, taking care not to over-tighten. The nail assembly instrument is removed. With the insertion handle positioned anteriorly, the nail is inserted manually over the reaming rod as far as possible into the medullary canal. The passage of the nail across the fracture is monitored with the image intensifier in 2 planes to confirm that the reaming rod has not dislodged, to confirm passage of the nail down to the intramedullary canal, as well as to monitor for malalignment. If necessary, the nail can be advanced with light hammer blows. The nail is inserted to the desired depth, which is indicated by the grooves on the insertion handle. The notch indicates the end of the nail. The subsequent 5 mm intervals between the grooves on the insertion handle correspond to the extensions of the end caps. Insertion depth can be verified with a lateral image using Blumensaat's line as a reference. The final position of the nail is checked in the AP and lateral views. The reaming rod is removed. To confirm the insertion depth of the nail, a 3.2 mm guide wire can be inserted through the small hole at the top of the insertion handle. The nail position is checked under image intensifier control in the lateral view, with the tip of the guide wire indicating the end of the RFNA. Fixation options. The standard locking and locking attachment washer techniques will be demonstrated in this presentation. standard locking. The instruments used include the aiming arm, the trocar, drill sleeve and protection sleeve, the 4.2 mm calibrated drill bit, the depth gauge, the retention pin, and the screwdriver XL25. To connect the radiolucent aiming arm to the insertion handle, the aiming arm is slid into the hook end of the insertion handle and then pivoted towards the insertion handle so that the latch on the aiming arm engages the catch on the insertion handle. To facilitate the insertion of the lateral to medial cross-locking screw, the 3-part trocar assembly is inserted through the desired hole in the aiming arm with the arrow on the protection sleeve aligned with the arrow on the aiming arm. A stab incision is made and the trocar is advanced to the bone. The protection sleeve is locked into place with a quarter turn. Note that the sleeves need to contact the cortex. The trocar is removed. With the drill sleeve pressed firmly to the near cortex, the drill bit is used to drill to the desired depth. While maintaining contact of the drill sleeve with the near cortex, the measurement is read from the drill bit at the back of the drill sleeve. This measurement corresponds to the appropriate length locking screw. Here, a screw length of 78 mm is measured. The drill bit and the drill sleeve are removed. The screwdriver XL25 is used to insert the appropriate length locking screw through the protection sleeve. The retention pin is turned counterclockwise to disengage it from the screw head and the screwdriver is removed. The protection sleeve is unlocked with a quarter turn and removed. The steps of trocar assembly insertion, drilling, determining locking screw length, and locking screw insertion are repeated for the additional distal locking screws. With the drill sleeve pressed firmly to the near cortex, the drill bit is used to drill to the desired depth. The drill bit and the drill sleeve are removed. For the insertion of the next locking screw, alternate instrumentation will be shown. The depth gauge is inserted through the protection sleeve. The position of the depth gauge hook is confirmed, and the depth gauge sleeve is firmly pressed against the near cortex. The measurement is read from the depth gauge to determine the appropriate length locking screw. The screwdriver XL25 quick coupling, attached to power, is used to insert the appropriate length locking screw through the protection sleeve until the head of the locking screw is close to contacting the near cortex. The power tool is disengaged before the screw is fully seated, the quick coupling handle is attached, and the final tightening of the locking screws must be completed with the manual detachable handle. The screwdriver is removed. The protection sleeve is unlocked with a quarter turn and removed. Another locking screw, this time from anterolateral to posteromedial, is inserted using the same steps. To facilitate the insertion of the next locking screw from anteromedial to posterolateral, the bone is rotated in the clamp and the screw is inserted using the same steps. The bone is rotated in the clamp to return it to its original position. The aiming arm is disconnected by disengaging the catch from the latch on the insertion handle and sliding it out of the hook end of the insertion handle. The combination wrench is used to loosen and remove the connecting screw. The insertion handle is kept in place to help align the 0 mm end cap to the nail. Using the screwdriver XL25, the end cap is inserted through the barrel of the insertion handle and tightened until secure. The screwdriver and the insertion handle are removed. The locking attachment washer is pre-contoured and is available in both 5-degree and 10-degree versions to account for screw hole position relative to the position of the nail in the bone. In this presentation, the 5-degree right version will be used. The instruments used include the aiming arm, 2 each of trocar, drill sleeve, and protection sleeve, 2 4.2 mm calibrated drill bits, the depth gauge, the retention pin, the screwdriver XL25, the holding device handle, the holding device locking pin, the SD25 star drive screwdriver shaft, the 6 Nm torque limiting handle, 2 bending drivers, the 3.5 mm VA drill guide, the 2.8 mm drill bit, the depth gauge for small screws, the screwdriver shaft, and the 2.5 Nm torque limiting handle. To connect the radiolucent aiming arm to the insertion handle, the aiming arm is slid into the hook end of the insertion handle and then pivoted towards the insertion handle so that the latch on the aiming arm engages the catch on the insertion handle. The nail is locked to the distal fragment with the medial oblique screw or with a drill bit in the medial oblique hole to limit motion of the nail relative to the distal fragment. The 3-part trocar combination is inserted through the medial oblique hole in the aiming arm. The protection sleeve is locked into place with a quarter turn. The trocar is removed. The drill bit is used to drill to the desired depth. The measurement is read from the drill bit at the back of the drill sleeve. This measurement corresponds to the appropriate length locking screw. The drill bit and the drill sleeve are removed. The screwdriver is used to insert the appropriate length locking screw through the protection sleeve until the head of the locking screw lies against the neocortex. The retention pin is turned counterclockwise to disengage it from the screw head and the screwdriver is removed. The protection sleeve is unlocked with a quarter turn and removed. The bone is rotated in the clamp The locking pin is inserted into the holding device handle. The locking attachment washer is attached to the holding device assembly by aligning the pin and tightening until secure. The locking attachment washer is positioned on the bone using the holding device such that the two 5.0 VA locking holes are aligned with the protection sleeves. The locking attachment washer is properly positioned when the holding device handle is pointed distally and oriented anterior to the protection sleeves. A sleeve assembly is partially inserted into each lateral to medial hole in the aiming arm. The locking attachment washer is held in position on the bone using the sleeves. Using the drill bit, the distal hole is drilled until the tip of the drill bit penetrates the far cortex. This drill bit is left in position by decoupling it from the power drill. Using a second drill bit, the proximal hole is drilled until the tip of the drill bit penetrates the far cortex. Using the drill bit, the appropriate length 5.0 mm VA locking screw is determined for the distal hole. The drill bit and drill sleeve are removed. The 5.0 mm variable angle locking screws may be inserted using power equipment and the T25 star drive screwdriver shaft, stopping approximately 1 cm before full insertion of the screw. For the proximal screw, the screw length is determined using the drill bit. The drill bit and drill sleeve are removed. This will allow manipulation of the locking attachment washer so as to improve the fit on the bone. The appropriate length locking screw may be inserted using power equipment and the T25 star drive screwdriver shaft, stopping approximately 1 cm before full insertion of the screw. The protection sleeves are removed. Both 5.0 mm VA locking screws should be approximately 1 cm proud of the locking attachment washer when proceeding to the next surgical step. The 3-part trocar combination is inserted through the lateral oblique hole in the aiming arm. The trocar is removed. The drill bit is used to drill to the desired depth. The drill sleeve is pressed firmly to the neocortex and the measurement is read from the drill bit at the back of the drill sleeve. This measurement corresponds to the appropriate length locking screw. The screwdriver is used to insert the appropriate length locking screw through the protection sleeve until the head of the locking screw lies against the neocortex. The protection sleeve and aiming arm are removed. Using the holding device, the position of the main body of the locking attachment washer is manipulated until the preferred fit on the bone is achieved. A precise fit of the posterior 3.5 mm VA locking screw tabs may not take place at this stage. The locking attachment washer is designed with 2 posterior 3.5 mm VA locking screw holes that can be contoured in situ in a later step. When the desired fit of the locking attachment washer is achieved, both 5.0 mm VA locking screws are tightened using the 6 Newton-meter torque limiting handle. The holding device locking pin is unthreaded from the locking washer and the holding device pin is removed from the handle. The posterior screw holes have a tab feature that enables bending in situ. The bending driver is used in situ to contour the tabs to the desired position. A second bending driver can be used in an adjacent screw hole to provide leverage for contouring. When using the cone end in the desired variable angle locking attachment washer hole, the drill guide tip is pressed firmly to ensure it keys securely into the cloverleaf portion of the variable angle locking screw hole. The notches on top of the cone are visual markers for the drill guide tip orientation. The cone will provide a secure window of 30-degree angulation. As an alternative, the drill bit and drill guide are removed and the depth gauge is used to measure for screw length. A locking screw is inserted using the T15 star drive screwdriver. Final tightening of the 3.5 mm variable angle locking screws must be done manually with the 2.5 Newton-meter torque limiting handle. The screw is advanced until locked. A hole is drilled using the 2.8 mm drill bit. The spherical tip end of the drill guide provides the possibility to choose the angulation. The lip portion of the spherical tip end engages with the cloverleaf portion of the hole to provide tactile feedback of the angulations. The combination wrench is used to loosen and remove the connecting screw. The insertion handle is kept in place to help align the 0 mm end cap to the nail. Using the screwdriver XL25, the end cap is inserted through the barrel of the insertion handle and tightened until secure. The screwdriver and the insertion handle are removed. Implant removal is an optional procedure. The instruments used include the extraction screw, the hammer guide, the combination wrench, and the combined hammer. The screwdriver XL25 is used to remove the end cap. And all but one of the locking screws are removed, leaving one locking screw in place. The most distal locking screw is removed. The extraction screw is threaded into the nail and tightened to prevent rotation or displacement of the nail. The single remaining locking screw prevents the nail from rotating while the extraction screw is inserted. The remaining locking screw is removed. The hammer guide is attached to the extraction screw. The nail is extracted with gentle blows of the spiral combination hammer. Summary. You should now be able to state the clinical indications, describe the correct patient positioning, recognize the surgical approach and entry point, perform reamed intramedullary nailing using the RFNA, and perform the key surgical steps.